point. My second point is, Dave, I love what you were saying. One of the things to think about is, over time, you know, people influence behavior, people's choices change. Like, so at the beginning, you know, you might say it's like, okay, so we're going to add this many more people because of choice, but some of the people started something when they heard about the other people, like, actually, you know, in 2 years they might have chosen something. So just to point it out, I'm sure you've thought about it.
All right. Anybody want to comment on that? Okay.
I absolutely agree with that. In fact, what we've seen with pre-exposure prophylaxis is that people are highly influenced by peers in context, and so that methods which I might be reluctant, for instance, to engage with an implant, but my friend got it and my other friend got it, and now suddenly the ick factor is maybe a little bit less.
Another question, it's Nancy.
Can I say a quick follow-up on that one?
sure.
Just a two-second follow-up on that one, which is I actually, and that particular response opens up a whole other area, I think, of thinking about optimal dynamic regimes as well as interventions that bring in network connections. And so how do you actually learn optimal rules for intervening on networks, not just offering the person what they're most going to benefit from, but somehow learning the best way to leverage their network connections to support them. And I think that's a really exciting frontier. Exciting methods work has been done, but you know, a lot to be translated.
Whereas ordinarily, is this on? Yeah.
You can.
I know.
Project.
You can project.
So I think it's worth talking a little bit about the difference between prevention and care, and what I'm getting at with that is, you know, in thinking about adaptive trials and actually rethinking about implementation science, where an outcome like coverage might be all you need to do, you know, rather than look at HIV incidence. But just to point out that if in the prevention world, like I was thinking of following your SMART tree out, you have, what are the external, how do you externally verify whether they're using the method or not? And whereas if it's in clinical care, you do have reasonable surrogates, like did you show up at the clinic? But I mean, I just think that the challenges, and where did James go? Oh,
Yes, he
we
has.
were talking a little bit, you know, do these cascades really apply for prevention? But just kind of thinking about it, that it's just a lot more challenging, I think.
All right, maybe one more question? Comment in the group?
I can respond to Nancy's if there's not. Or is there one? Go ahead. So a quick just response to that. I think there are multiple parts of that. Response to one part of that, which is, I think, a very interesting thing when we think about learning optimal allocation strategies, best ways of integrating preference with other variables, doing that in these sophisticated data ways, is the next step, which is taking how do we build those so they're maximally robust to transport to new contexts and new settings. And I think that's also a super exciting area that couldn't squeeze everything into 15 minutes, but we're going to hear lots more about transport, but I think it's an important topic.
So, yeah, thanks again for a great set of talks. So one of the things that some of the thinking about kind of, you know, implementation science and the relevance of findings and these adaptive designs, and you know, Maya and I talked about this before, is kind of like we're inching our way towards exploding this dichotomy between the lab and the system. And I don't fully have my head around how, but it seems like ways of adapting how you get information as well as what you are doing at the same time, like will bring us eventually to a place where, I mean, this is like the learning system like idea, right? So you're no longer trying to do something here and then say, okay, now we're going to do it in reality, but rather that the reality and the learning all go together. And you know, that's kind of maybe pie in the sky, but some comments on that would be fantastic.
I'm talking a lot. Someone else want to respond?
Go, go.
I mean, I obviously have lots of thoughts about this. We spent a long time thinking about it. I mean, I completely agree. I think, first of all, we have trial data. We're saying average treatment effect. We can do so much more for that setting with the trial data, with methods we have. Then we have new trial designs, right? We can do better with our trial designs as well as asking better questions with our trial data. But I think, and then we could talk about doing a good job transporting the results of our trial findings to new settings. But I absolutely agree that the place that we should be heading to is getting out of that framework altogether, where the interventions we're talking about are actually learning systems. And so you're not like, let's learn here, and now can we modify it? Does it hold up over there? I don't know. But it's more like, how do you build a system that you can put in place that actually the system is going to adapt to context and needs and patient changes and still continue to deliver the most effective interventions? And so I think that is, I mean, I don't know, you got everyone together to work on things. I mean, I think that is a super exciting thing to work, and really is going to require people from across disciplines.
All right, well, I think I'm cutting
Oh,
into the
wait.
break time here,
Can I-
so someone, maybe this will be our last comment. Would you like to respond?
No, I think that's, I mean, I think we see more and more that we are starting to build these databases which follow up whole populations. And I think that's where we can really start thinking about a self-learning system, which will involve observational data, obviously, and they will generate ideas. And we can use the state-of-the-art methods for that, but also learn from that and say, you know, what about doing a randomized trial within this population, maybe in subgroups of the population, and we can start doing that. And all these things come together, and there is not in any way like a separation anymore. It's one big sequence which is learning and growing in that manner. And then you don't even have the question, oh, does it work? I mean, you are doing it in the real world.
Can I make one?
Yeah.
Yeah, so just like, so I think we're all on the, I don't know if that's actually working or not.
Maybe try this one.
I feel like we're all completely in the same place as to kind of that's the way you want to go. And, you know, so Nancy, I was thinking when you were talking, like, I was just thinking about the program that we both know in Zimbabwe where we see clients of a sex work outreach program all the time. And, you know, when you start thinking about this vision, you start thinking, okay, so what could you ask in that system, and how could you set up designs to understand preferences and where people are, and then I just sort of, you know, the sort of not remotely well specified point I made about ethics and leveraging opportunities, and just I think we're united in the vision, and then I just think of the challenges of operationalizing that vision, and that's, you know, we should rise to those challenges, but they're profound, I think, in thinking about how you would communicate those sorts of designs and the kind of decisions that would make providers have to deal with, you know, data that if you're changing allocate. Just, yeah, that's. I know you're not saying it's trivial. It's just that's profound.
All right, well, we need to give one more hand of applause to our panel. Thank you very much.